Hari. Right. Okay. Hari. So the plan for the next few days is, so we are almost at the end of your appointment, which is good. And I hope that I think we've covered everything that we need to. And the plan for the last few weeks is like this. Okay. So your exam is on Thursday and Friday. Dinuka Thursday OSCE and Friday Viva neda.
ඒක නම් කිව්වේ නෑ සර් මේ
සාමාන්‍යයෙන් Friday Viva එහෙම මොකක් හරි. So whatever it is, right? So what I was thinking was, today let's finish off the neurology short cases with the limb examination and stop it there. The next few days, let's finish off the emergencies. I'm quite keen to finish the neurology because that's the most difficult thing. And if we did the cranial nerves the other day, so let's finish that today. Then let's halt the short cases for a moment and then finish off the emergencies. That will take 2 days. So Wednesday, Wednesday, Thursday, maybe a little bit of Friday. So this week, let's finish off the emergencies. That gives you enough time to study for the Viva. Okay. And then first thing next week, let's do the OSCE, right? So either Monday or Tuesday. And then and immediately after so let's come back to the short cases, maybe immediately after the appointment or something like that. Let's finish neurology because that's the most difficult. The other ones are not difficult at all. And then we will probably revisit when we have time. But let's finish off the ones that are coming for your exam first. And then let's find some time to do the cardiovascular and respiratory short cases. එහෙම හොඳයි නේද දිනුක? නැත්තම් මම බැලුවේ මේ ළමයින්ට පාඩම් කරගන්න මේ acute medicine ඉවර කරගත්තොත් හොඳයි කියලා ඉස්සෙල්ලා. හා?
ඒක හොඳයි සර්.
හරි. එහෙම කරමු එහෙනම්. Okay, fine. Right. Okay, so screen එක පේනව නේද?
ඔව් සර්.
Okay, right. So that day we discussed cranial nerve examination, and today let's talk about the upper and lower limb examination related short cases, right? Now, this is easier because we have discussed this before. Okay, when we were doing the long cases, we discussed some aspects of these before. So I've just given a few cases as examples, and let's try to work through them so that we get a good idea of how to approach a neurology limb examination short case, right? And again, like in cranial nerves, in the upper limb, lower limbs, again, your focus is to answer 2 questions. To understand where is the lesion, which is the localization, and to understand what the etiology of the lesion is. Now, remember, in a short case, it might not always be possible to identify the etiology, but you should be able to identify the location or the localization, right? So that is important to remember. All right, so let's start with case number 1. Before we read this case, I have to remind you, I think this is something that I taught you before. When you have a limb examination short case, when you finish the examination, you should be able to categorize your physical signs into a group. So if you don't remember this, write this down. I've told you this before, but write this down again if you don't remember, right? So you should be able to categorize your findings into a group, right? So what are these clinical groups, right? So the clinical groups are 1, pure upper motor neuron signs. Okay, pure upper motor neuron signs. Group 2 is pure lower motor neuron signs, right? Then group 3 is a mixture of upper motor neuron and lower motor neuron signs. Okay, so these are the common 3 groups. Occasionally, you might get extrapyramidal signs as the 4th group. Okay, extrapyramidal signs, which is Parkinsonism. And number 5 is cerebellar signs, right? So these are the 5 groups. Okay, these are the 5 groups. So what are the 5 groups again? Pure upper motor neuron, right? Pure lower motor neuron, mixed, extrapyramidal, and cerebellar. So these are the 5 diagnostic clinical groups in the limb examination. All right. Okay. So let's go with the first case. Okay. All right, I'll give you a few minutes to just read and understand this case. So first you try to group it into one of the 5 groups. Okay. So from the physical signs, let us localize the lesion first. Okay. Right. So what group does this patient belong to? This patient belongs to group number 1, or pure upper motor neuron signs. Pure upper motor neuron signs. Right. Now, when you have a person with pure upper motor neuron signs, there are several patterns of involvement. Okay, several patterns of involvement, and we discussed this before as well. So, what are the patterns? You can have a patient with pure upper motor neuron signs who has hemiparesis, right? Hemiparesis, weakness of one side of the body, and stroke and etc. we talked about. Okay, and then you can also have patients with paraparesis or quadriparesis. Paraparesis or quadriparesis. So this patient falls into the group of paraparesis. Right? So now, before you have done any sort of analysis, you have understood that the patient has a upper motor neuron, pure upper motor neuron clinical syndrome, and we have a patient with paraparesis. Okay, any questions about that interpretation? Right. Okay, fine, good. Now then, this is again something I taught you. Now we need to find where the lesion is. Right. So I have told you this before. When you have a patient with upper motor neuron paraparesis, the lesion has to be above T12 and L1. Okay, the lesion has to be above T12 and L1. Okay. Okay. The reason for this is that when you have upper motor neuron signs in the whole of the lower limbs, okay, the lesion has to be above, okay, the first or the highest innervation of the lower limbs. The lesion has to be above the highest innervation of the lower limbs, because both lower limbs are spastic. So the lesion has to be above the top root that supplies the lower limbs, which is L1. Okay. So when you have upper motor neuron paraparesis, then, right, in the lower limbs, the lesion has to be above L1 T12 level. Okay. Right. Is that clear? Any questions about that? So you have to understand that very clearly. Upper motor neuron. So the lesion has to be above the lower limb innervation. The lesion has to be above the lower limb innervation at L1. It will be window. You cannot upper motor neuron lower limbs. Right. So L1 T12 is that level. Any questions about that? Right. Fine. Now, once you do that, look at this algorithm. Okay. You look to examine a sensory level. Okay. To see if there is a sensory level. Okay. That's the first thing that you need to do. If there is a sensory level, the lesion is exactly at that level. The lesion is exactly at that level. So, then balanna. Oops. May patient, there is spastic paraparesis. So we know that the lesion is above T12 L1 in the spinal cord, right? And this patient has a sensory level, right, at T10. So therefore, we can say quite clearly that the patient's lesion is at T10 in the thoracic spinal cord. That's very clear. Okay, very clear. Right. Now look at case number 2, and we'll come back to this algorithm. We'll come back to this algorithm with case number 2 there. So read this now. Upper limb එක බලන්න එපා. මේ පළවෙනි point එක විතරක් කියවන්න. Right, so the command is examine the lower limbs. You have read only the first point here. First point එක විතරක් කියවන්න. So when you finish examining the patient, your findings are again a patient with spastic lower limbs, spastic paraparesis. අපි අත් දෙක තාම බලලා නැහැ. What you know at the moment is the patient has spastic paraparesis. You know that, right? Then අපි ආයන් මේ algorithm එකට. Right. So spastic paraparesis, I told you that the lesion has to be above T12L1 in the spinal cord. Okay. And the next thing you look for is a sensory level. If there is a sensory level, like case number 1, the lesion is exactly at that level. So the T10 tiburani, so the lesion is exactly at T10. Okay, fine. Right. Then the next thing to do, right? The next thing to do, if there is no sensory level, what do you do? Now remember, due to various lesions, sometimes in spinal cord problems, the motor pathways can be preferentially affected. The sensory can be normal. So it's only the motor part that goes, or predominantly the motor part that goes. So sometimes you have the situation like in case number 2, where you find spastic paraparesis, but there is no sensory level, no sensory signs at all. Right. Now, if you have that situation, there is another way of localizing the lesion, and that is to examine the upper limbs now. That is to examine the upper limbs. Then බලන්න මම මේ laser point එක දාගන්නම් මේකේ. එතකොට now you have to, so no sensory level, right? Now you examine the upper limbs. Examine the upper limbs. So in this case, case number 2, we know that the patient has spastic paraparesis, but there is no sensory level because it's just the motor pathways that are affected probably. So now we know that the lesion has to be above T12L1 spinal cord, but we can't localize it any further because there is no sensory level. So now what do? You tell the examiner, I would like to examine the upper limb reflexes. Ek examiner කියනවා. ඒ කියන්නේ because they just asked you to examine the lower limbs. No? So lower limbs examine කරන්න කියපුවකොට upper limbs examine කරන්න එක වැරදි without asking. So you say, sir, I found these got these findings. I would like to examine the upper limbs reflexes. ඒ ප්‍රශ්නේ ඔබලා ඇහුවොත් එහෙම automatically you get a set of marks because we know as examiners, this guy knows what they are doing. කියලා අපි දන්නවා. Right? Okay. Right. Now, examine the upper limbs. When you examine the upper limb reflexes, there can be 3 types of possibilities. Right? දේවල් 3ක් වෙන්න පුළුවන්. First possibility, all the upper limb reflexes are brisk. So when you examine the upper limb reflexes now, all the upper limb reflexes are brisk. Okay, right. All the upper limb reflexes are brisk. Okay. When that happens, now remind yourself of the innervation of the upper limb reflexes. So as you know, the biceps is C5, C6. Triceps is C7, C8. Okay. Supinate is C6, C7. So for all the upper limb reflexes to be brisk, the lesion has to be above what point? The biceps. So that's C5, C6. So if all the upper limb reflexes are brisk, the lesion has to be above C5 and C6. Right. Any questions? Right. Okay. Okay, so spastic paraparesis we found at the exam, no sensory level. I will tell the examiner, sir, I would like to examine the upper limb reflexes now. Okay, then the examiner says, go ahead. You examine the upper limb reflexes. All upper limb reflexes are brisk, brisk. So now you can say, because you know that the biceps reflex is the highest, and that's C5, C6. For all the reflexes to be brisk, the lesion has to be above C5 and C6. Okay. Then above C5, C6 කිව්වම තැන් ගොඩක් වෙන්න පුළුවන් නේ. So cervical cord වෙන්න පුළුවන්. Right? Or brain stem වෙන්නත් පුළුවන්. Brain stem වෙන්නත් පුළුවන්. Okay? එම් වෙන්න පුළුවන්. So how do you figure that out now? Right? Examine the jaw reflex. Right? Jaw reflex. That is the next thing to do. ඔච්චර කරන්න විභාග වෙලාවක් හම්බෙන්නේ නැවට අහනවා අපි. හරි? So all reflexes, now you know the lesion is above C5, C6, and the lesion could be in the upper cervical cord or it could be in the brain stem. Right? It could be in the brain stem. So for that to localize, අපි තව එක උඩ reflex එකක් බලනවා. right? So what is that reflex? That is the jaw reflex. If the jaw reflex is also brisk, you know the lesion is in the brainstem somewhere, and that is it. Don't worry beyond that. So if the jaw reflex is also brisk, you know it is in the brainstem or above. එතනින් උඩ කියලා. අපි දන්නවා ඒක. එතනින් එහාට ඔක බලන්න අවශ්‍ය නැහැ. That's it. Right. But if the jaw reflex is normal, now you know the lesion could be in the upper cervical cord. Could be in the upper cervical cord. If the jaw reflex is normal, the lesion could be in the upper cervical cord up to the medulla, because as you know, the jaw reflex is in the medulla. So, right. There is one more thing you can do now. And there are a set of physical signs that are specifically positive, and underline that word, specifically positive, if the lesion is at C1, C2. Exactly at C1, C2. That is the foramen magnum. Foramen magnum. Okay. So all upper limb reflexes brisk. Jaw reflex brisk nang lesion above sort of brainstem or above. If the jaw reflex is normal, then you know the lesion is in the upper cervical cord. Right. In the upper cervical cord, there are specific physical signs that occur when you have a lesion at C1, C2 level. Right. And what are these physical signs? Number one, downbeat nystagmus. Downbeat nystagmus. Right. Downbeat nystagmus කියන්නේ අපි සාමාන්‍ය විදිහට you ask the patient to look to the side to elicit nystagmus. Normally the nystagmus goes මෙහෙමනේ. Right. Downbeat nystagmus මේ පැත්ත බලන්න කිව්වත් the eye goes up and down. So it's a vertical nystagmus. So you'll check for nystagmus in the usual way. පැත්ත බලන්න කියනවා. ඇහැ මෙහෙම යන්නේ නැතුව මෙහෙම යනවා. Right? That is vertical nystagmus. That's a very interesting sign for foramen magnum problems. C1, C2 level again. Okay. That's one sign. Another sign is something called mirroring of movement, where you ask the patient to close the eyes and sort of move. So move one hand fingers. So fingers ඉබේටම යනවා. So when they start moving the fingers of one hand, the other hand will also start moving. That is called mirroring of movement. Mirroring of movement. And these two physical signs occur exactly when the lesion is at the foramen magnum level. So that is C1 and C2. Okay, right. So that is one type of findings you might get. Okay. Okay. Any questions from that? So upper limb, so you do the thing, no sensory level, examine the upper limbs, all upper limb reflexes are brisk, that tells you the lesion is above C5. Okay. Examine the jaw reflex, if that's brisk, the lesion has to be above that, no? So in the brainstem somewhere or higher up. If the jaw reflex is normal, that tells you the lesion is definitely in the cervical cord, and you can look for specific physical signs. If the lesion is exactly at C1, C2 or foramen magnum, you will get downbeat nystagmus and mirroring of movement. Right. Any questions from that part? Okay, right. Now, the next type of thing you might get when you examine the upper limb reflexes, so watch the laser pointer, you might find that when you examine the reflexes, pattern absent biceps reflex, absent biceps reflex, exaggerated triceps reflex, and inverted supinator reflex. Inverted supinator. Okay. Again, ask somebody in the ward to show you on a patient. Go to neurology, there will be plenty of patients, or in neurosurgery, to show you what an inverted supinator reflex looks like. Okay. So what do you get here? So this is a second possibility when you examine the upper limbs. Biceps reflex normal, triceps is brisk, and supinator is inverted. Inverted supinator reflex. If you get those signs, the lesion is exactly at C5, C6, right? If you get that collection of signs, the lesion is exactly at C5, C6. Because the biceps absent, supinator brisk, and triceps is brisk and the supinator is inverted. So then the lesion is exactly at C5 and C6. Okay, right. That is fine also. Okay. The third possibility you might get in the when you do the limb examination is that, right? What is the thing you might get? Upper limb reflexes are normal, right? So when you do the upper limbs reflexes, the upper limb reflexes are normal. So here the lesion has to be below T1, right? Because remember, biceps is C5, C6, supinate is C6, C7, and triceps is C7, C8. Okay, so if all the upper limb reflexes are normal, then the lesion has to be below T1, and you can say the lesion then is between T1 and T12 in the thoracic cord. There are further ways of narrowing that down, but that's a bit complicated, and I don't want you to know that at an undergraduate level. Hari, tava puluang T1, T12 අතරටත් you can localize it, but that is a bit postgraduate, so no need of doing that. Hari. Fine. හරිනේ බලන්න. එතකොට this is a patient where you find when you do the lower limb examination spastic paraparesis without a sensory level. If there is a sensory level, it's fine, no problem. මේවා එකක්වත් කරන්න ඕනේ නැහැ. And the level of the lesion will be the level of the sensory level. So here there is no sensory level. So we use the upper limb reflexes to localize it further. Three possibilities. All upper limb reflexes brisk, and that could be above C5, C6, and you can diagnose foramen magnum lesions with specific physical signs. Second possibility, absent biceps, inverted supinator, exaggerated triceps, lesion is at C5 and C6. If all the upper limb reflexes are normal, the lesion has to be below T1, right? So therefore, we can say T1 to T12, the thoracic cord, right? Any questions? So where is this patient's lesion then? So spastic paraparesis, no sensory level. So examiner, can I please examine the upper limb reflexes? Go ahead, when you examine the upper limb reflexes, biceps reflex is absent, triceps is brisk, and supinator is inverted. So now you know, according to this little algorithm that I have given you, the lesion has to be at C5 and C6 in the cervical spinal cord. Okay, that's it. Right. So now we have done two patients with sort of spastic paraparesis, very different approaches. When there is a sensory case one, easy, no kata, no sina, very easy to localize. When there is no sensory level, you have to ask the examiner, can I examine the upper limb reflexes? And using the upper limb reflexes, you can further localize, as I have just shown you how to do. Any questions from that part of it? Right. ප්‍රශ්න තියෙනවද? ඔයාලා හැරලා නේද ඉන්නේ? No kata, no sina. Hari. Hari. Okay, fine. Right, so let's go to case number 3 then. Right. Now let's read case number 3 first. Okay, wasting in the legs, bilateral foot drop, proximal powers 4 out of 5, distal powers 2 out of 5, all in all movements around the ankle, both ankle and knee jerk were absent, and JPS was lost. My case. Right. Okay, right. Now here we have this table that I have told you when we were doing the long cases. Right. I'm just going to revise this now quickly. I'll send you the slides after the class so that you have this. Short case. Okay. So I told you now this patient belongs into group number 2, where the patient has lower motor neuron signs. Lower motor neuron signs. Okay. So when they have low motor neuron signs, and this is again paraparesis, low motor neuron type paraparesis. If they have low motor neuron signs, the lesion could be in any place along the low motor neuron pathway. Remember that? Okay. So the lesion could be in the muscle, the lesion could be in the neuromuscular junction, the lesion could be in the peripheral nerve, the lesion could be in the plexus, root, or anterior horn cell. Okay. And I also told you that sometimes when you have an acute spinal cord problem, right, because of spinal shock, the signs can mimic a lower motor neuron type lesion. Right? Okay. right? And I taught you the very specific patterns of neurology in a lesion in any of these places. අපි එකත් කතා කරන්නේ long case කරනකොට නේද? There is a very specific pattern of neurology when there is a lesion in these places. දැන් මම එක මතක් කරගෙන යනවා ඉක්මනට ඔයගොල්ලොත් බලන්න මතකයිද කියලා. Right. Right. So what are the cardinal features of a muscle lesion or a myopathy? බලන්න දැන් මේවා කලින් කියලා දීලා තියෙනවා. Bilateral, symmetrical. Right? Proximal predominant. Proximal more than distal. Bilateral symmetrical, proximal more than distal. There is minimal muscle wasting. Minimal muscle wasting. Reflexes, remember I told you reflexes may be preserved, right? But may be diminished proximally. But reflexes are usually preserved unless it's a really end-stage myopathy, right? Because the reflex arc is okay. Nerve ke prasnyak naha. Reflex arc is okay. There is obviously no sensory loss. There cannot be sensory loss in a myopathy. Okay. Then in neuromuscular junction disease, specifically myasthenia gravis, I told you they commonly have cranial nerve sort of cranial nerve innervated muscle involvement. Ptosis can be kata karnකොට මේක කතා කරා. They have ptosis, extraocular muscle weakness predominantly in addition to the limb weakness. And the key feature is fatigability. And their reflexes are preserved and there is no wasting and no sensory loss. Fatigability is the key feature here. මේ වගු එක නෑ ඒක ඔයගොල්ලෝ දාගන්න මේ ස්ලයිඩ් එක හම්බුණා. Okay. Then peripheral nerve, I told you there were 3 patterns of neurology. Polyneuropathy, mononeuropathy, mononeuritis multiplex. And in polyneuropathy again මතකයිනේ bilateral symmetrical disease polyneuropathy. And then usually distal predominant except in certain exceptions like Guillain-Barré. Distal predominant, but in Guillain-Barré you can have both proximal and distal involvement, right? And the sensory the reflexes being absent or diminished is a key feature of a polyneuropathy. Polyneuropathy can diagnose karan epa if the reflexes are there, right? So in polyneuropathy almost always the reflexes will be gone, right? Right. So that is important. Sensory can be a glove and stocking sensory loss, length dependent or glove and stocking sensory loss because all the longer nerves are affected. First, right? So bilateral symmetrical, distal more than proximal. Reflexes also can follow that pattern, but it's usually absent. Length dependent sensory loss, right? That is polyneuropathy. Mononeuropathy, I told you, the distribution is neural distribution. It's a very focused impairment. Only the muscles affected by that nerve will be weak, and only that sensory area supplied by the nerve will be impaired, right? So it is a very neural pattern of distribution, And mononeuritis multiplex, you told me that you got that in one of your practice short cases that we did as a department. So that's a very patchy, asymmetrical sort of neurology. Okay. Right. Then root and plexus, root and plexus, root has always a dermatomal and myotomal distribution. Dermatomal and myotomal. And I told you to study all the dermatomes, study all the myotomes, right? So it is a dermatomal and myotomal distribution. And I gave the example T1 nang gihila tiyenne, all the muscles innervated by the T1 myotome will be weak, and the T1 dermatome, there will be sensory loss. Eka matakai. And plexus essentially is a combination of multiple root sort of patterns, right? Plexus. Finally, anterior horn cell. Remember, I told you anterior horn cell, we're talking specifically about motor neuron disease. So bilateral asymmetrical disease. Fasciculations are very common. And I also told you, remember, motor neuron disease can also affect the upper motor neurons. So you might get a mixture of upper motor and lower motor neuron signs. There will never be any sensory loss because the sensory is in the posterior root of the spinal cord and not in the anterior part, right? Not in the anterior horn cell. It is in the posterior horn cell. So there is no sensory loss, right? Right? The last one is spinal cord that can mimic a lower motor neuron, but they will usually have a sensory level, right? Well, that is quite common, right? We'll get. All right, so this is how you approach. Right? This is how you approach a low motor neuron problem. So this is the second or third time that I'm telling this now. Any questions? Any questions?
සර් මේ වගේ මේ උඩම පේලිය අන්තිම පේලිය දෙකම එකයිද?
Oh, ඒ වැරදිලා. Hi. Okay. So in the absence of questions, let's go back to this case number 3 and see where the lesion is. Where the lesion එක. So it's clear that it's lower motor neuron. Where is the lesion? Looking at this table, where do you think it is? Go. Ko kawure giya bang? Api ne වැරදුනට ප්‍රශ්නයක් නැහැ. නම් කියන්න කලින් කිව්වනම් හොඳයි නේද? Stunned silence.
Polyneuropathy, sir.
Yes, Sarani. Why do you say it's a polyneuropathy?
Because one thing, tone is distally is more than proximal, and it's symmetrical with absent reflexes, and both the sensory is also involved.
Yes. Okay, fine. So that's absolutely right. So this is a sort of textbook appearance of a polyneuropathy. Textbook. Sensory glove and stocking kak nae. Sarangani, can you tell me, now this is a little advanced, but can you tell me, is this more of a large fiber polyneuropathy or a small fiber polyneuropathy? Can you give me that additional bit of information for distinction marks?
Large.
What is the fundamental difference between small and large fiber is that the large fiber nerves carry most of the joint position sense, the higher sort of sensory modalities. Pain, temperature sort of thing is carried mainly by the smaller nerves. Okay. So here, because the joint position sense is involved, Sarangani, where is this predominantly a small fiber neuropathy or a large fiber neuropathy?
Large fiber.
Yeah. And also motor, especially reflexes, all are carried mainly by the larger fibers. So this is a very typical picture of a large fiber polyneuropathy, but exam make extra details avashya naha. We're just asking for interest. Okay. So hema kiyannat puluwa. Okay, fine. So this is a polyneuropathy based on this table that we saw. Any questions about that?
So is joint muscle sensation affected in anterior horn cell?
No. That's sensory. Anterior horn cell is sensory. No sensory involvement, and joint position is sensory. And joint position travels anyway in the posterior part of the spinal cord, right up to the top. Okay, right. Hari, make a balloon. So patient has a right-sided foot drop, right, with weakness of eversion around the ankle. Ankle reflex is present, and there's very focal sensory loss. Focal sensory loss, right? So what is this? So this again, this has to be a low motor. It can't be an upper motor neuron by any stretch of the imagination. It is a low motor. Then make a kotanda TN. Where is the problem? So you can directly exclude certain things from it. Make a very focal right? So it cannot be muscle or neuromuscular polyneuropathy. ඒවා වෙන්න බෑ නේ. Anterior horn cell ඒවා එකක්වත් වෙන්න බෑ because it's a very localized problem. Whenever you have a localized problem, you have to decide only two things. So localize නේ. ඔය foot drop, wrist drop පනම්මන ඕවගේවා when it is so localized, there are only two possibilities. One is it the nerve or the root. ඔච්චරයි decide කරන්න ඕනේ. Right? It can't be a polyneuropathy. අනම්මන ඒවා වෙන්නම බෑනේ. Can't be. So your decision is this a nerve lesion or a root lesion? Now applying it to this case, what is the nerve? Common peroneal. Yeah. Root is L5S1. So here the only decision you have to take now, is this a root lesion or a nerve lesion? So is this a common peroneal nerve lesion on the right or is it a L5S1 root lesion? හරි කියමු බලන්න. දැන් ලේසි කරලා තියෙන හොඳටම.
common peroneal nerve. Peroneal.
Oh, so Imal can yaba both say common peroneal. එකක් කියපන් දැන් ඇයි එහෙම කියන්නේ කියලා. ඇයි මේක root එකක් වෙන්නේ නැත්තේ? Why is this not a L5S1 root lesion?
If it is root lesions, both eversion and inversion both would be.
Very good. So L5S1 also supplies inversion. Inversion and also to a certain extent dorsiflexion and plantar flexion. So around the ankle, most of the movements are L5S1. So if it's a L5S1, you are very correct, Yapa. Yes, the inversion should also be affected. Yes. Another reason why this is not root.
The ankle reflex is present?
Yeah, the ankle reflex is also majority innervated by L5S1, right? So because it's preserved, there can't be a problem in the root. If there was a root lesion, the reflex would have been absent. Another reason why this is a nerve and not root. So
the sensory loss pattern.
Yeah, the sensory loss pattern, exactly. The sensory loss pattern is beautifully confined to the common peroneal nerve territory. මතකනේ අපි කියන neural distribution. In a nerve lesion, it is always neural distribution. So it will be confined to that nerve territory. Confined to that nerve territory. Okay. Fine. Brilliant. So this is a common peroneal, right-sided common peroneal nerve lesion. If it was a root lesion, then you would have foot drop plus weakness of most of the movements around the ankle. The ankle reflex would be absent because it's all myotome. And the sensory loss would be in the dermatome of L5S1. And if you look carefully, L5S1 also extends to the sort of sole and posterior aspect of the leg also. So that is the sort of picture you would get in a root lesion. Right. Any questions about that thinking, that analysis? Okay, fine. Okay, case number 5. Kievan. Hari, මේක කොහෙද තියෙන්නේ? පොඩ්ඩයි. Sorry. මේක කොහෙද තියෙන්නේ?
So is it a motor neuron disease?
Yes, why? Is it a exam එකෙන් ප්‍රශ්න අහන්න තහනම් exam එකට කියනවා exam එකෙන් ආයි ප්‍රශ්න අහන්න එපා. Is it නෙවෙයි, why do you say it's anterior horn cell motor neuron?
There is lower motor type of wasting and reduction of power, and the reflexes are brisk. So there is mixed upper motor and lower motor neuron sort of pattern.
Good. Yes. Hari. And that occurs, as you know, as I've shown you in this anterior horn cell disease, and there is no sensory loss. Additionally, it is confirmed that this patient has motor neuron disease, anterior horn cell disease. Okay. Any questions about that case? Hari, good. No questions. Hari. Hari. Make a balance. So this patient has bilateral small muscle wasting of the hands. Okay. No sensory loss. Small muscle wasting and weakness in the hands. No sensory loss. Right? No sensory loss. What are the possibilities? So I've not given you the complete findings. Just told you that bilateral small muscle wasting and weakness of the small muscles of the hands. No sensory loss. What are the possibilities? Then I balance table එක මතක් කරගන්න. දැන් කියන්න මොකද්ද කියලා. You have to be a bit more specific than that.
T1 root
තවත් specific වෙන්න ඕනේ. දෙපැත්තමනේ ඉමල්ක. එතකොට
bilateral.
exam එකේ උඹලා ලකුණු ගන්න නැත්තේ ඕකයි. දැන් exam එකට ඇවිල්ලා කියනවා root lesion කියලා. root lesion exam එක උඹලෙන් ආයි ප්‍රශ්න අහනවා. මොන root එකද? ඊට පස්සේ දැන් root එක ඇහුවට පස්සේ හරි. ඒක T1 root. Then is it unilateral bilateral කියලා කියන්න එපා. So එකපාර උත්තර this is bilateral T1 root lesion. හරිද? Yes, I agree, but
Yes.
Against it මොකද්ද? ඔයා කියපු එකට පොඩ්ඩක් slide against යන දේ මොකද්ද? root lesion එකට. Yeah, the absence of sensory. Neda, Imalka, do you agree with that statement? Because there is absence of sensory, then you have to specify say this might be a motor root. Ne? Motor pad එක විතරක් ගිහිල්ලා වෙන්න පුළුවන්. Ne? It's not wrong, it's a possibility. මොකද අපි වෙනේම මම මොකක්වත් කියලා නැහැ. I haven't given you the full examination. I have just given you a little bit of information. හරි. වෙන මොනවද වෙන්න පුළුවන්? So Imalka is right. It might be a bilateral T1 root lesion. Unusual thing is there is no T1 dermatomal sensory loss. Hari. තාම මොනවද වෙන්න පුළුවන්? What are the other possibilities? දැන් ඉමල්කයි යාපයි යරෙන වෙනෙවුන් ඉන්නවනේ මේ group එකේ. දැන් කියපන්. නම් කියන්න කලින්. කො?
So mononeuritis multiplex.
දිනක mononeuritis multiplex is an asymmetrical problem. හරි? මේක symmetrical නේ. දෙපැත්තම එක වගේ නේ. Mononeuritis multiplex is usually an asymmetrical problem. This patient has symmetrical wasting and symmetrical weakness. ලැජ්ජ වෙන්න එපා. කියන්න.
So anterior horn cell එක වෙන්නත් පුළුවන් නේද?
පුළුවන්. Yes, good. So it might be anterior horn cell disease. දැන් පුළුවන් ද කියලාත් අහනවද විදුවයි? පුළුවන්. එහෙම කියන්න. So I'm not joking. හැමෝම එහෙම තමයි. මේක you have to present කියලා exam එකේ නඩුවට මේවා serious දේවල්. You have to present cases and exam එකෙන් ප්‍රශ්න අහන්න නැතුව හරියට present කරලා diagnosis කියන්න. Right. So bilateral, yes, it could be anterior horn cell disease, wasting තියෙනවා, weakness තියෙනවා. It's slightly asymmetrical anterior horn cell, but that's a possibility. නේ? That's a possibility. තව මොනවද වෙන්න පුළුවන්?
So polyneuropathy with motor neuron involvement.
Yes, polyneuropathy, but that you have to specifically say pure motor polyneuropathy. Ne? It might be a pure motor polyneuropathy. Why? Distal, ne? Distal TNA, right? Then symmetrical, right? But there is no sensory loss, so you have to say it's a pure motor polyneuropathy. Hari? Okay. So that case is just for you to think of the possibilities. Ne? Ek among full findings dila naha, but think of the possibilities. So using this table, you can work anything out. කියන එක පෙන්නන්න තමයි අපි මේ කියන්නේ. So a patient, if you just look at only a few things. The exam එකේ බලන්න. දැන් ඔයගොල්ලෝ ලෙඩක් දැකපු ගමන් ඔළුවට තුනක් එනවනේ නේද? ඒකයි මම ඔයගොල්ලන්ට උගන්වන්න හදන්නේ. Then when you see the patient's hands to bilateral symmetrical wasting දැක් ගමන් දැන් මතක් වෙන්න ඕනේ. අර ටේබල් එක මාව මතක් වෙලා අර ටේබල් එක මතක් වෙන්න ඕනේ. මතක් වෙලා දැන් ඔන්න right. T1 root වෙන්න පුළුවන් මේක දැන් අපි ලෙඩට අත තියලවත් නැහැ. T1 root වෙන්න පුළුවන් bilateral, anterior horn cell වෙන්න පුළුවන්. This might be a motor polyneuropathy. ඒවා දැන්ටමත් ඔළුවට එනවා. ඒතර examine කරගෙන යනකොට අපිට hina යනවා දැන්. ඇඬෙනවා examine අය මේ case එක මට දුන්නේ කියලා ඇඬෙනවා දැන් මේ එච්චර lazy case එකක් කියලා දැන් ඔය තුන විතරයි මට හිතන්න තියෙන්නේ. Right? And using the other signs you can work it out what exactly it is. Ne? Right. Okay. Any questions about that one?
Sir, could this be a myopathy? Sir?
Very unusual due to two reasons, Sarangini. One is myopathies are usually proximal, right? And there is wasting is uncommon in myopathy. Wasting is uncommon. However, saying that there are exceptions, Sarangani, there are exceptions of distal myopathies with wasting, but those are postgraduate. We won't give you, and those are exceptions to the rule. Remember, medicine always has exceptions. No? So 99.9% of myopathies are proximal, but there are a small group of distal myopathies that can present like this also, but those are very, very rare. So rare common. Yeah, thank you for asking that question. It's a very important question, but don't focus on rare things. But it's rare. Hari. Okay, clear?
Sir, could this be a plexopathy in a lower brachial plexus?
Oh, that's very unusual. Very, very unusual. Brachial plexopathies are usually unilateral, and lower part is unusual scene. I have never seen that sort of thing before.
If
it is
theoretically unilateral, sir, it is possible.
If it's unilateral, it's a different story, but still again, to involve one small part of the brachial plexus is unusual. Unusual. Unless there's some tumor specifically compressing that part, unusual.
Okay.
Right? Right. So I have now gone through this sort of lower motor neuron algorithm story. I'm going to give you one more thing. Now make a hitala mata kiyapam mokadda kiyala. Okay. So a patient comes, the neurology is unilateral. Unilateral. Say right side right. Okay. Right. So unilateral. Right side. Left side is normal. Right. On the left side, the patient on inspection has wasting of the muscles around the shoulder joint. So the proximal muscles around the shoulder joint are wasted. Fasciculations, godak neveyi antan tiyeno. Fasciculations, but wasting tiyeno. Right? Okay. Right. When examining the movements, C5, C6, C7 related movements are weak. Okay. C5, C6, C7 related movements are weak. Okay. Right. They were weak. Reflexes. Biceps jerk is absent. Biceps jerk is absent. But supinator and triceps are present. Biceps supinator and triceps are present. Right? And there is a sensory loss in the C5, C6, C7 dermatomes. Sensory loss in the C5, C6, C7 dermatomes. So wasting around the shoulder on inspection with a few fasciculations. Weakness of C5, C6, C7 related movements, like shoulder abduction or movements keep weak, but corresponding to C5, C6, C7. Reflexes, biceps is absent, but triceps and supinator. Biceps is absent, supinator is also absent, triceps is present. So biceps, supinator, dekama triceps එක තියෙනවා. And then dermatomal sensory loss in C5, C6, C7. Okay. Now tell me, where is the lesion? This is a real case that we gave once for a short case. But yes. So where is the lesion? Okay. You can give a differential diagnosis also for the lesion, but there are two possibilities. You can tell me the two possibilities. Make a hitala balan kiyan.
Radiculopathy.
Again, Sanoj ne lagi Sanoj?
The left side, C5, C6, nerve rotation.
The Imalka podda hondai. Sanoj, now remember the problem with your thing. Radiculopathy kila hariyan naha, Sanoj. You have to tell exactly ne. Right-sided ne. Monoradiculopathy da hema kiyan nun. So Imalka's answer is better than yours because Imalka has told mokadda Imalka ay kiyan walan. අනේ උඹලා මම ලංකාවේ හිටියන උඹලා මස් කරනවා මේ ෂෝට් කේස් වල පෙන්නන අර
left side C5 C6
left නේ මම right කියලා නේද කිව්වේ right නේ කිව්වේ හරි මොකක් හරි හරි right side මොකද්ද
C5 C6
C7
nerve root lesion.
Nerve root lesion. Very good. Why do you say that?
Because there is weakness of those muscle groups.
Yes.
However, and the reflexes of biceps and supinate are absent. And however, the triceps is present.
Yes.
So, and the sensory level is also involved in those three.
Good. Right. Sanoj දැන් හරිද ඒක? එම ලස්සන්ට කියනවාද ඊගා පාර ඇහුවම? Sanoj මොකද තරහ වුණාද පිටින්නේ?
Yes, sir.
මොකද්ද?
Yes, sir, I will tell.
Like that. හරි. Okay. හරි. Right. Any other possibilities?
Sir, since it's multiple roots, I think it's more likely to be the right side. C5 is the plexus.
Okay, so doing the says challenges Imalka might be the plexus also, especially the upper part of the plexus. C5, C6, C7 plexus. Hari. Then doing the Imalka අතර තියෙන ප්‍රශ්නේ විසඳන්න කෙනෙක් දන්නවද මොකක් හරි? Yeah.
Lateral cord, it could be lateral cord.
Yes, it could be part of the plexus. A plexus එකේ කැලලක් වෙන්න පුළුවන්. It's very difficult to localize it exactly onto the plexus කැලලම, but another possibility is because there are multiple roots involved, it might be a plexus also. Plexopathy, plexus lesion. Hari. Now using your method anatomy distinction තියෙන උන් ඉන්නවද? දැන් හිරුනි උදාහරණයට anatomy distinction එකක් තියෙනවා කියලා මම දන්නවා. නේද? කො හිරුනි? මොකද්ද? නැද්ද? හරි. හිරුනිට පුළුවන් ද ඔය ප්‍රශ්නේ විසඳලා දෙන්න අපිට. මේක plexus ද root ද කියලා? So I'll make it a little bit easier. Are there any nerves that are given off at the root level before the brachial plexus is formed? Hiruni. In the upper limbs, are there any nerves that are given off at the root level before the plexus is formed? අයියෙන් කියන්න බබ ඔය කටහඬම් සද්ද ඒක ඒ ගානම තමයි. Yes.
Long thoracic nerve.
Long thoracic nerve and yes, what is the other one Hiruni? Suprascapular එකයි තව එකක් තියෙනවා nerve to rhomboids කියලා එකක් තියෙනවා නේද?
Subscapular nerve.
Oh. So there are some nerves lamai, especially the long thoracic nerve, the nerve to rhomboids, which are given off before the formation of the brachial plexus. Harida? Right. Now, in order to resolve the debate between Imalka and Dinuka, whether this could be a plexus lesion or a root lesion, what you do in this particular patient is still the examiner. I would like to examine two specific muscles. Hari, Sherlock Holmes age dewa kiya panditaya wage. Monawada balanne api? Examine the rhomboids and the long thoracic. Right? Long thoracic එක බලන්නේ winging of the scapula, right? And rhomboids වලට කරන්නේ මෙන්න මෙහෙම මේක පිටිපස්සට මෙහෙම කරනවා. Right? Oh. If those nerves are weak, then you know it's a root, multiple roots involved at the root level, right? If those nerves are normal, then එතනින් එහාට that is the plexus, right? So what are the nerves? Nerve to rhomboids and this suprascapular nerve examine data. Amari long thoracic එක පුළුවන්. Winging of the scapula බැලුවොත් these lesions are given off right near the root. So in a root lesion, those nerves will also be affected. But if it's a plexus lesion, those nerves will be normal. එහෙම තමයි ඒක විසඳන්නේ. exam එකේ ඔක්කොත් ක්ලියර් distinction එකක් දීලා ගෙදර යවනවා. හරි ඔහම case එකක් ඇවිල්ලා ඕක discuss කරොත් එහෙම you will definitely get a distinction. හරි? හරි. So the two possibilities in the case scenario which you have, please write that down. හරි ඒක ලියා ගන්න. Possibilities are C5, C6, C7 nerve root lesion වෙන්න පුළුවන්, or it could be a C5, C6, C7 part of the brachial plexus being involved. Hari? How you differentiate that is examine two nerves which are given off before the formation of the brachial plexus. So if it's a brachial plexus lesion, those two nerves will be normal because they are given before. ඒවා මුලින් යන්නේ. right? So those are the nerve to rhomboids and the long thoracic nerve. Hari. Any questions? That's a bit advanced, but take a mole kalpana karan igana ganna thanak utana. Hari? A case එක. Hari. Any questions?
සර් විගින් එක බලන්නේ අපි පිටිපස්සෙන් කියලා තල්ලු කරනවා.
පිටිපස්සෙන් කියලා තල්ලු කරනවද? පිස්සුද කවුද පිටිපස්සෙන් කියලා තල්ලු කරන්නේ?
අත ඈත් කරනවද මොකද කරන්නේ?
නෑ මෙහෙම කරන්න පුළුවන් නිකන්. හරිනම් බිත්තියකට ගිහිල්ලා මෙහෙම තද කරන්න කියනෝනේ. ඒව කර කර ඉන්න බෑනේ. විභාගෙදී නිකන් ලෙඩාට අත මෙහෙම තියලා ඕගොල්ලන්ගේ අත මෙහෙම තියලා තල්ලු කරන්න කියන්නේ. එන ඕගොල්ලන්ගේ අත මෙහෙම තියලා ලෙඩාට පුෂ් කරන්න කියන්නේ. එතකොට you will see the wing.
නෑ that is begin එක rhomboids.
Rhomboids එක මෙහෙම අත් දෙක තියලා පිටිපස්සට ඔහම තද කරන්න කියනවා.
Against resistance so නිකම්
yeah against resistance yes. So දැන් ලෙඩා මෙහෙම ඉන්නවා නම් අත පිටිපස්සෙන් තියලා මෙහෙම තද කරන්න කියනවා. You keep your hand behind the ඔහම තද කරන්න කියන්න පුළුවන්. හරි.
Okay sir thank you.
So upper limb examination එක motor examination එකේ ඔය දෙක
ඒවා සාමාන්‍යයෙන් බලන්නේ නෑනේ ළමයි. නෑ routinely බලන්නේ නෑ. ඔය වගේ අවස්ථාවකදී විතරයි ඒවා බලන්නේ.
Okay.
Sir one more thing මේ fasciculation වල තාට්ටු දාලා බලන්නට ඕනේ නැත්නම් just see the
තාට්ටු දාන්න එපා පිස්සුද? අම්බෝ චෑන්ට හන්නේ හැදේ. උඹලා තාට්ටු දැම්මා. තාට්ටු දාන්නේ. ඒක වැරදි. That's a wrong technique. හරි? මේ තාට්ටු දාන්න එපා. නිකන් just observe. හරි? මේ සමහර එක්සැමිනර් තද වෙනවා එක කරා. මොකද දැන් ඉන්ස්පෙක්ෂන් වල තාට්ටු දාන්න බෑනේ. You can't tap when you're doing the inspections of fasciculations are inspection things. හරි? තාට්ටු දාන්න එපා. තාට්ටු දැම්මම වැඩි වෙනවා. ඒ වුණාට ඒක කැතයිනේ බා. ඔහොම නිකන් එහෙම කරන්න එපා. හරි. හරිනේ. Okay, fine. Right. So just to recap then when you have the limb examination, easy, split it up into a group. First group is pure upper motor, second group is pure lower motor, and third group is mixed. තව දෙකක් තියෙනවා ඒවා නම් වැඩි විභාගයට දෙන්නේ නැහැ. extra pyramidal cerebellum. හරි ඒවා වැඩි විභාගයට දෙන්නේ නැහැ. ඒතර upper motor neuron I have told you how to approach. Lower motor neuron I have given you several examples of how to approach. Mixed එකක් මම කියලා තියෙනවා නේ. Mixed එකේ මොකද්ද most likely possibility if you have a mixed upper motor neuron lower motor neuron issue is motor neuron disease, right? That is a most likely possibility. තව පොඩි possibility එකක් තියෙනවා මෙන්න මෙහෙම. If there is a spinal cord in the mixed group, එක පොඩ්ඩක් ලියා ගන්න. In the mixed group most likely it is motor neuron disease, හරි? But there's a slight possibility where you might have a bigger spinal cord lesion. ටිකක් දිග එකක්. Over several spinal segments. එතකොට you can also get a mixture of upper motor neuron, lower motor neuron size because it's extending over several spinal segments. එක තැනක් නෙවෙයි over a length. In that case also you can get a mixed upper motor neuron, lower motor neuron sign, right? ඕක වෙනවා මෙන්න මේ වගේ syrinx එකක් තියෙනකොට syrinx එක දිගයිනේ. එහෙම වෙන්න පුළුවන්. Also, when there are multiple discs pressing on the spinal cord at various levels, cervical spondylosis, multiple discs pressing on various levels of the spinal cord, also you can get that sort of phenomenon. Hari? Hari. That is it. Any questions?
Sir, අර mixed එකේ මේ ඒක long මොකක් කියලාද කිව්වේ? ඒක පොඩ්ඩක් තේරුම්.
Long is a spinal cord lesion extending over several spinal segments, not a single place, over several spinal segments, like syrinx or multiple discs compressing the cord, say C5 to C6, ඔක්කොම disc එක cord එක compress වෙනවා. So you can't predict නේ. Upper motor neuron signs උත් වෙනවා, lower motor neuron signs උත් වෙනවා, mix එකක්. Because there are multiple levels being compressed. Yeah.
Okay. Okay. Thank you.
Hari. Okay then. හිට කරමු එහෙනම්. So let's sort of temporarily stop doing the short cases. දැන් ඇත්තටම නියුරෝ තමයි අමාරු දැන් කාඩියොලොජි නම් ඒවා ලොකු ප්‍රශ්නයක් නැහැ ඇත්තටම. This is the problematic one where you need to sort of think a little bit. All the others are just reminding sets of physical signs and diagnoses. So let's do the emergent acute medicine things first for your bypass, so you have enough time to study that, and then we'll see OSCE එක කරනවද තව short case ටිකක් කරලා OSCE ගන්න වෙලා තිබ්බොත් we'll do it like that. But let's finish off the acute medicine things, and I think we should ignore the OSCE also before we go back to short cases because it will give you some time to study also. Hari. Hari, හෙට කරමු.
Thank you, sir.
Hari, okay.
Thank you, sir.
Hari. Okay, bye.
Thank you.
Okay, bye.